technology is so amazing. Luckily, you well rehearsed your talk because I realised I'm supposed to be keeping to time, and I wasn't watching my clock at all until quite to the end. I'm like, oh my God, what time is it? And you were good. So, because your videos were so engrossing. So, what are the barriers to seeing this, widespread throughout surgery throughout the world?
Right, it's a great question. So one is expense. Right now, the systems are expensive. So we spent quite a bit of money to acquire the system. We rented it initially.
Where does the expense come in? Is it the technology that does the
It's the equipment
scanning?
that processes it.
Okay.
Yeah, no, the scans are done routinely. So we take a DICOM image of a CT scan, CT angiogram, or a angiography, or an MR scan, and Molly, who's sitting in the back, processes it with the currently the surgical technology software, and then we can offer the rendering of it. So the equipment to plan it, the equipment to visualize it right now is expensive. So you have to be willing to make an initial investment. I actually was able to persuade several donors to give money. I mean, it's some of the patients when they see this are blown away.
Yeah, well, you said mind-blowing, and I thought, oh, that was.
I didn't say it. She said that.
Was that an intended pun? Because
that was the patient. That's a good pun. Yeah. Yeah. Okay. So that I would say right now is, and the systems have to get better. So this is the first generation, really, and there'll be more. It'll get even better and better in terms of refining the ability to manipulate the images.
Thank you. And we've got a lady. Where'd she go? With her hand up really early. Yes. Okay, so we've heard one of the challenges, which Gary said was cost. Gentlemen, do you have other advances on other challenges?
Yes, so for, at least on the DoD end of, for the robotic telesurgery, we're in a unique position in the sense that we don't have some of the biggest barriers that robotic telesurgery really faces on the civilian side, which is having to deal with credentialing, licensing, medical, legal. That's a whole different layer of infrastructure that needs to be built up for this to really find a market in the civilian sector. And this is coming from a lot of conversations with people who have done this for a while, and including Intuitive Da Vinci Surgical. You would expect that because they already have their robots, it's ubiquitous. But, and being able to have those robots communicate, the base system's there, because that's initially what the Da Vinci robot was created for. It wasn't created for minimally invasive endoscopic surgery. It was created for robotic telesurgery. So the capability is there, but they are very honest, and they say, listen, there isn't the market that there isn't enough of a market for us to be able to take on those challenges to create that whole new infrastructure. Maybe over time, as things get pushed along, maybe on the DoD sector, as we overcome the technical challenges, because we don't have some of these barriers. If I have credentialing at one institution of the DoD hospitals, I'm credentialed everywhere. So with licensing and with medical legal, I have universal coverage with all these places. So, we can overcome that. It's the technical, so we can focus on the technical challenges.
That time lag that you had in your presentation, which
that's the biggest technical.
Yeah, that's the biggest technical challenge, and I think that's an issue for any, whether it be augmented reality, virtual reality, or anything. You're doing something with teledistance, you have to try to somehow account for that. So.
Yeah. Okay.
Go ahead.
And I think I just wanted to reiterate some of the points that were raised, and also perhaps address some of the ways in which we were tackling them, because there are challenges I think that we're all facing, but in different approaches. I think one is sort of infrastructure, and it's how do you manage the bandwidth, the requirements, the hardware, the cost of the hardware. So those were challenges that we faced early on when we were looking at AR and looking at kind of what hardware we're going to use. And it's probably the biggest driving force, which is why we went to a software system only that could integrate with any hardware. Because one, it means it's scalable, it's kind of cost effective. You don't have to install a big, wearable technology or different, you can kind of work with what you have. People are using hardware that they already pre-own. Bandwidth is an issue. We've worked to some extent to mitigate that as much as possible with doing, my co-founder is actually a telco engineer, has been that for 20, 25 years, with bandwidth adaptability. So we can work with, it sort of senses the bandwidth and kind of adapts the imaging and adapts the feed accordingly in terms of how high definition it is and drops. So we've done surgeries in Kandahar in the field, we've done it in Gaza and Syria in the field, and we've done stuff in the US at Yale in different kind of levels. So that is a challenge. I think with 5G and other things coming out, that hopefully will be solved. And then in terms of that whole host of medical legal, I mean, we've had those same discussions with the robotic industry, and I think the industry is shifting. I think people are accepting more, just like patients are accepting more that their data should be shared, that the data is powerful. I think people are accepting that actually to get that best care is probably going to have to be some form of telesurgery in whatever format, whatever hardware system that you use. But those are issues, and I think it's those initial pioneers that are going to pave that way. And it is a learning curve. I mean, I think we're all kind of trying to get that feedback from patients, from medical legal. We've tried to mitigate it as much as we can through our licensing agreements, but I think licensing and credentialing is probably one of the issues that we'll still face.
I would just comment we're doing robotic surgery and neurosurgery in spine. We're putting in pedicle screws, and for epilepsy surgery, we're putting in electrodes robotically. But the Da Vinci system and the best robotic systems are still not nearly good enough to do the kind of surgery I showed you, sewing with Tenno suture in a very tiny, tiny space. So we've got a ways to go if we're going to be doing robotic surgery, of that kind.
Yeah, we're working on micro surgery as well.
Yeah.
More on the scale of 8.0 sutures, but you're right. And one of the exciting things about our project is when I was meeting with the engineer that we connected with, I told him we want to do robotic telesurgery, and we need to write some grants let's make this happen. And he said, that's exciting, but there's nothing novel about this. We have the technology that can make this happen. And I said, what do you mean you have the technology that can make this happen? As clinicians, we need to make it. We need to make it work. So it's really just about bringing people together and a lot of hard work.
So Garnett Sutherland is a neurosurgeon in Calgary. He's been a pioneer in robotic surgery, and he's got a third-generation robotic system which has the advantage of haptic feedback. You know what haptic feedback is? That's the ability to feel what you're operating on. That is just as important as the visual. And he operated in Canada on a patient in New York, actually, who had a brain tumor. It's more primitive surgery where you're kind of just taking it out with, not as delicate instruments. And of course, there was a surgeon backup there. But when this first was designed, they had to actually go to a bank to do it. He doesn't now, but he had to go to a bank because the banks had the most secure and fastest DSL lines. But now we've matured, and you can actually, many of the universities have it. And so the technology is, it's all coming together. We never could have done this without the advantage in computer technology and imaging.
Yeah. There's another question from the audience. Everyone's blown away. Yeah, well, I was going to ask you mentioned haptic technology, and like we've talked about the technical barriers here, and not to go down the gutter or anything, but this is true, that haptics are really of interest to the porn industry. So, yeah, as I said, a little bit gutter, but I'm keeping it high level. But it's true, it actually is, and there's huge amounts of money if the haptic technology works, where you can actually do whatever you want to do, and have that actual feeling. So
remotely,
it'll be interesting to see if I couldn't imagine a research grant where you're working in some dodgy industry, but it could be that medical pioneers, technology pioneers, in this side industry, because a lot of other technology has been from other industries. So.
Definitely, it's coming into surgery. It's just like you said, it's the maturity of
it's still
getting there, but it's still quite mature. Just like a lot of the wearables, is still quite
I know
mature.
Tesla's working on haptics as well. Their suit looks really cool. It's all white and it looks very science fiction. Any other comments? No one wants to pick up on the porn. Surprising.
Well, with the use of the wearables for AR and VR, I think it's brilliant in the sense that the people that will really drive that forward will be video gamers.
Yeah.
Actually, and that's the exciting part is that I used to get yelled at when I used to play video games, but now I think we're going to be thanking them for the future of surgery because they will really be the ones that drive the improvement in the graphics optics. So I think, there's going to be a lot of work ahead. And, fortunately for us, we can kind of sit in the back seat and let them drive that, and we can focus on the other difficulties. So.
Yeah.
When we have young patients, kids who were demonstrating the system ahead of surgery, showing their anatomy, they put on the glasses, the 3D glasses, you can't take it off them. And they're whipping around their brains in 3 dimensions in ways that, I can't do because they grew up with this, so.
Yeah, that's impressive. Okay, no other questions then? Oh, we do have one. Brilliant.
I haven't seen your talk, so thanks a lot that's really exciting work and beautiful surgery too, by the way. So, as a head neck surgeon, I've operated a lot with the da Vinci system. But it seems like as exciting as I get at these talks, I come back to the financial realities. We have to figure out a way to convince our payers that in fact we're really showing value.
Yeah.
And then we can have these great toys that really help us do amazing work. How have you started to think about how you're going to government or insurers that there's real value to this? Are you measuring outcomes? And give us some wisdom.
That's a great question. Yeah, we have some projects right now which are looking at outcomes. Now it's difficult to to quantitate. So some of the outcomes are patient engagement, patient satisfaction, and that's important. That's just as important in some ways as the clinical outcome. But we'd like to eventually show that that the results are better, that it's safer, there are fewer complications. Ultimately, less time in the OR. So those are some of the areas we're looking at. But we're just starting this now. It takes a while to get CMS to approve it. So as an example, we developed one of the first radiosurgery systems here, stereotactic radiosurgery. The CyberKnife was invented by John Adler, one of my partners. There was no code for that. There was no reimbursement. I had to persuade the hospital to donate $1 million to get it going. And then over time, we showed outcomes are better. We showed it's valuable. And now we make $10 million a year just at Stanford on stereotactic radiosurgery. So it does take time. The other thing we're looking at is to see our conversion rate, how many patients, because some of my patients look all over the country to find a surgeon if it's an elective case. How many of them are coming to Stanford rather than elsewhere? So, but you're right. We have to figure out a way that we can bill for this ultimately, instead of depending on philanthropy and some hospital support.
Thank you. Thanks, Gary. Questions?
Yeah. That's a great point. Both of my teachers, my mentors when I was a resident, Jay Canberry and Jerry Silverberg, ended up having surgery on their necks, probably for that reason. So, the move actually now is away from microscopes to what are called exoscopes. And so this is very high definition camera, but you don't have to have your head over the microscope. You operate looking at right now it's a 2-dimensional, like an endoscopic screen, but it will be 3-dimensional. But I can foresee using the glasses in the future. So you're right. Hopefully it'll protect my neck.
Other reasons. Yes, another.
And I also wanted to congratulate Dr. Roscoe for their work. What do you think the first battlefield thing you built?
That's awesome.
Yeah, I mean, I think that the biggest application is in traumas, and so right now the robot is used for minimally invasive intracorporeal, transoral types of approaches, but the first implementation may be for something external, so maybe a tracheotomy in the field or something like that. But
you saw we're developing, retrofitting a existing robotic platform with SRI. It's 15 pounds. It's durable. You could ship it out to the field, and all it needs is a motor or some type of energy source. And it's really made for something that's external. there was a recent requirement that came out by the DoD, and one of the objectives is that by 2024, we will have a system that's deployed as a prototype, but the first task for us is to do a cricothyrotomy to obtain the airway somehow using that robot. So that will be something that has to be done by 2024.
What about a craniotomy? I mean, to take out a blood clot, an epidural or subdural hematoma. Do you have drills that are compatible with the robot that you can put a hole in the skull?
Not that I know of now, but
Because that's a pretty simple operation.
Yeah. From an engineering standpoint, it's not a hard thing. It's just the hardware. It's just figuring out how the robot gets stabilized and drills in.
Should be easy.
Application.
We'll work on that.
Yeah, we should.
Okay. So what you're also saying is also we're a while off from Alien, where you go into, if you've seen that movie where a woman gives herself a cesarean by getting rid of the alien, and there's no humans involved, it's just a robot. So we're still a while off from that.
Yeah.
Okay, that'll be a while.
That's true, yeah.
Cool. All right. Well, if we don't have any other questions and been inspired, we'll wrap it up. And thank you very much for your presentation.
Thank you.
You guys as well.